Good morning, everyone. Thank you all for joining the session here. It's titled Management of Acute Stroke. I'm very happy to have Dr. Sana Al-Khawaja from Bahrain moderating this session here. My name is Dr. Yasser Abul-Hassan. I'm replacing the moderator, Dr. Tamer Abdelhaq. This is our day 3 of the conference. It's always exciting to have people on board here. We have an esteemed faculty list. Our first faculty, Dr. Jamil Deboo, I would like to welcome him to the stage. Dr. Deboo is a consultant intensivist in neurocritical care at Cleveland Clinic Abu Dhabi, UAE. He completed a neurocritical care fellowship at the Cleveland Clinic in Ohio and a neurology residence at the University of Arkansas. He's going to be talking to us about blood pressure management and intracerebral hemorrhage versus ischemic stroke. Welcome to the stage, Dr. Deboo.
Thank you. Thank you, Yasser. And again, thank you to all the organizers. It's been an incredible conference, incredibly well organized, and it's a great pleasure to talk to you today in this hall about a juicy topic. And I'm trying to make it practical. I do less theories, less pathophysiology. I just want to try to get you to think about how to approach these patients and what to do on a practical basis, and I hope it comes in handy. So the topic is about blood pressure management, and hemorrhagic stroke is ICH, or intracerebral hemorrhage. So every time we're gonna say ICH is not intracranial, it's specifically for intraparenchymal hemorrhage and ischemic stroke. I have no disclosures. So I'll start with the blood pressure management in ICH. Intraparenchymal hemorrhages, and just a quick background, we know they form a significant amount of portion of all the strokes that you get to the ICU, maybe a quarter you would say, or a third, and they're very high, they have very high mortality. And even the ones that survive, they have high morbidity. And to me is one of the big things, or for all of us as practitioners, and we talk about it in a lot of areas in neuro-ICU, is the nihilism or the approach to these patients. Once you have a big bleed on CT scan, you already are entering the patient's room with the kind of this nihilistic barrier in your mind that they're not going to do well. So there's plenty of etiologies which we're not going to go through, but obviously investigating them is key. And there's plenty of early complications that come with these patients with ICH. But in blood pressure management, what you're really trying to do is you're trying to prevent hematoma expansion, more or less, and the edema formation by controlling the blood pressure. And hematoma expansion can be devastating, and it carries a high mortality and morbidity that adds up to already the bad prognosis that carries with these patients when they present. Now, what I love the most about this, and this is one of the key takeaways, and I'm going to repeat it in this next 5 minutes, is the recent call for action about having a code ICH, which doesn't exist in what acute ischemic stroke is enjoying nowadays, but we don't do that in ICH. So you can see clearly on your left hand, the code stroke I'm sure all of you have code stroke in the ED. It's a very well automated system where they come in, you do CT, CTA, CTP, you know your target blood pressure, you know what blood labs you're gonna get, and then who gets TPA, who gets thrombectomy, done. Very well automated, but then if you look at the ICH side, there's not consistency or the sense of urgency to evaluate these patients. Like, do you do a CTA or not needed? This is hypertensive or not? What's your target blood pressure? How fast do you get it? How much pressure do you put in to get it started? The standards are wishy-washy in terms of reversal. There is some evidence, and even neurosurgically, evidence has been weak. So along the path of evaluating and treating these patients, it's also been not well managed. So the bundle of care is very important, and that's the message that needs to be delivered. And part of it is the blood pressure control, is amongst the bundle of care that encompass reversing anticoagulation, calling neurosurgery, doing the right evaluation, blood pressure control is very important. And I think some of you have seen this before, but to make it simple is tough in blood pressure management. And I love this editorial by Dr. Robinstein. about blood pressure management. And what it says basically is you have two similar, the big evidence comes from two big trials, and they have different conclusions that can confuse anybody. However, as always, the devil is in the details. So it's not about the target, but it's about how and when you reach it. So it is very confusing literature, but it's not just really about the target. Just keep that in mind. And it's about the timing. It's about how the intensity of bringing it down, and then the agents that you use. So what is the target, right? Are we targeting blood pressure? Are we targeting diastolic? Are you targeting mere arterial pressure? Are you targeting systolic blood pressure? And what are the numbers, right? And why is it systolic? Why is it not mean arterial pressure? Why is it 180? Why is it 160? And I'm sure if I ask all of you, and just maybe you can raise of hands, is what's your target when you admit these patients? Who says A, 130? Like, what do you target systolic blood pressure on admission? Is it 130? Anybody? Raise of hands. 140? Anyone in their protocol? 140? Wow, that's a good chunk. 150? All right. 160? Anybody? All right. All right, there you go. Now the guideline says 130, 150. So I think there's a lot of different targets. The guidelines say 130, 150, but it hovers around 140. It's very variable, and I think it applies to subarachnoid hemorrhage. It applies to others, but let's talk a bit more about it. So we know everyone has a high blood pressure at the beginning. We don't know if is it the chicken or the egg. Is it they're in pain, they're in distress, or is it the high blood pressure? I'm not taking your meds, getting ICH kind of. But really, the main data that comes behind, or the evidence come in this target blood pressure, comes from these two trials, all right? INTERACT-2 and ATTACH-2. I'm not going to go through them. We can do hours of journal club on these and many other studies. But you can, what you want to see is although they're same but different. In terms of, they have the same goal at the beginning, but there's some variability in terms of how fast they treated them, what's the average blood pressure they reached, and essentially ATTACH-2, for example, their average systolic blood pressure was on the lower side. But what we learned from them, and even what we learned from them and what the guidelines kind of spit out from these big trials is lots of, the devils were actually in the details, specifically about the timing, the intensity, and the agents used. And so the 2022 guidelines for managing the blood pressure, so first and foremost, what they recommend is continuous, smooth, and sustained control, and you avoid the variability and the peaks in ICH. That's the first take-home message. When you get a patient with ICH, you want to control the blood pressure, it has to be continuous. You shouldn't have variability. And there are studies showing this variability in blood pressure, and the spikes contribute to hematoma expansion. And the second is, if you get them anywhere from 150 to 220, bringing them down to 130 to 150 is reasonable, so hovering around 140, all right? This is supported by many of these trials. And why 130? Because ATTACH-2, for example, showed that less than 130, you get in trouble and lots of complications, and specifically kidney dysfunction. And then, and this is where the harm is, and there's good evidence. If you drop them too low, you're going to harm them. But the data is weak in the large ICHs and so on and so forth. But keeping in mind that 130 to 150 is key, and when you instruct your nurses to do nicardipine, put it on, don't say less than 150, because it could be less than 150, they can turn it on and the patient is 110. That's still less than 150, but that's not good. You want to just keep it up close in that range to make sure they don't overdo it and cause hypoperfusion. So now there is a recent call to action in terms of code ICH, which I find it to be incredibly important, and I hope we get to streamline how we did for acute ischemic stroke, to streamline the process when they present. And it's basically trying to mimic when the patients come in and you do a CT scan, you find a bleed. There should be some sense of urgency to get your nicardipine, get your reversal agent, do your CTA, and then obviously a big part of it is the blood pressure control. And similarly, what they propose, and maybe that comes into play, similarly as you have these door-to-needle for all your acute ischemic stroke metrics on the left side, why not having it on the right side similarly to ICH? because we know, so I even remember that when the patients come to you, although we say, oh, repeat CT scan in the first few hours to check for the expansion, but then the patient already presented a few hours after he was witnessed down. It's rarely that they bring you the patient within the hour of onset of action. So usually they brought him down, the EMS got there, they transferred from another hospital. That's already many hours passed by. So the faster you act in the ED, you may also be late already, even if you streamline your process. And the bundle of care, again, this is a good recent paper that came out in Interact 3, not just at blood pressure, they looked at bundle of care, and obviously a big part of it is blood pressure control. It's a very good paper also that calls to action that it's not just, of course, just about blood pressure control, it's about everything else that you can add, the glucose and all that stuff, add it together, and it matters, and it shows that patients do better when you do aggressive, early bundle of care approach to ICHs. And so that's my take-home message. Think about it, blood pressure is more than a target, and think about managing ICH as a bundle of care, out of which controlling blood pressure is key. And I'll move on to acute ischemic stroke, which is more streamlined, more evidence-based, I guess, in some ways. And we know that also a lot of patients with acute ischemic stroke, they present with high blood pressure. And again, is it the background, is it chronic hypertension, is it sympathetic response? And then we know that too high and too low blood pressure when they present can lead you to a worse outcome. So there's that, there's that range in the middle that, have better outcomes, as some studies have shown. So why is it important to manage blood pressure in ischemic stroke? And this is very important to understand that one of the, you want to understand why you're doing what you're doing, is you're trying essentially to salvage the penumbra, or the about to die brain area that is not dead. Let's make it simple. And in general, when the patient comes in with a stroke, you can see that there's an occluded artery. There's an occluded artery that leads to an ischemic infarct here, but there's some area that still has room to survive that is not dead yet. And the blood pressure, providing the proper perfusion via the blood pressure may help with that, alongside providing thrombolytics and mechanical thrombectomy. And obviously, you have to keep in mind the autoregulation, which is shifted to the right side, which is dysregulated in these patients. So the more you increase your blood pressure, the perfusion is going to go up, and vice versa to the brain. And obviously, why we do then CT perfusion is more or less to see the same. And so that's what you're checking. You're checking, do I have a penumbra? Do I have an area that I can salvage to intervene upon? And this is also, blood pressure management helps. And another reason, and obviously why it helps not to have high blood pressure versus too low. If you have it too low, that penumbra becomes an infarct. And if you have it too high, then you may risk of hemorrhagic transformation. So there's a balance there. That's why it's important to control the blood pressure. Another reason to give you to control the blood pressure, although all the thrombectomy now is standard of care, and then it helps in outcomes. But look at the numbers. If you've achieved TK2b or 3, your MRS and modified Rankin scale is not that high, even in the best of these studies. So why is it that also thrombectomy, if you recanalize, that you're not having great outcome? It could be that all the other factors and the bundle of care that you need to also optimize alongside mechanical thrombectomy, including blood pressure management. So again, approaching blood pressure management, honestly, personally, I would approach it the same for all cerebrovascular disease, subarachnoid, ICH, and ischemic stroke. What are your agents that you're using? Is it consistent, smooth? Everybody gets an arterial line. And same thing you want to think about in acute ischemic stroke. So I would classify them, say, you have the TPA group or without TPA and the thrombectomy group. And why is that? Because of the updated guidelines of the 2018, the 2019 ones. It's clear evidence that, not too clear in this group. So patients that come in with ischemic stroke without TPA or thrombectomy, you're okay to allow them up to 220 or 120, up to 180, whatever that is. You can let them do whatever they want to do, obviously not higher than that. So this is not great evidence, but allowing perfusion in these patients, it's okay. Patients with TPA is descended upon us from the old trials. It's 185, 110 before you give TPA, and then it's 180, 105, no budging right, left, or center. These are the numbers, You put them in, it's very easy. Now, the biggest challenge is with mechanical thrombectomy, and this is where the trials and the evidence is weaker, and this is where we need to figure out what to do. Not to bore you with these, but there's plenty of trials, and I know Enchanted 3 is up and coming, and we're going to be part of it as well in Abu Dhabi. There's plenty of trials, but as you also know, there's different targets in blood pressure. This is blood pressure control after thrombectomy. These trials are not in synchrony. They have different targets, different patient population, different, even they're not heavily, like Enchanted 2, and I think the other one, Optum VP, maybe they're heavy, they have most of the patients. And so there's a lot of variability, even achieving which targets they achieved and then what ages they use. So there is lots of variability, but to extrapolate from these patients, from these studies, what it shows is it does favor actually conventional BP management, meaning not intensive. So when you finish thrombectomy, successful thrombectomy, don't bring down their blood pressure in a very aggressive way. Letting them be is better. It's favoring it. It's not hardcore evidence, again, because of the variability of the studies. So extrapolating from all of this pool of the studies, basically what the recommendation is, if you have good TK2B3 recanalization, so controlling them not too aggressive, again, in the range of the magic number of 140 to 160 is key. And then obviously, if you don't recanalize, it makes a bit of sense to just let them ride up to 180, but not too high, so you avoid luxury reperfusion and probably ICH conversion. And this is a nice schematic as a summary of how you control it. You want to think about them as phases. So you have phase 1 in the ED. Are they TPA candidates or not? Are they thrombectomy candidates or not? Not too low, not too high. And then if you give TPA, you have your magic number there. You also, we didn't talk about this, but this is another topic by itself. What do you do in the angio suite? Again, it's very hard to control the blood pressure, but it's very key. Not too low, not too high. And then what happens when you reperfuse? And that's it. Thank you.
Thank you very much, Dr. Jamil, for the interesting presentation. Our next speaker will be Dr. Michael Dringer. He's a certified in psychology. He's a neurophysiopharmacology and medicine. He completed a neurology resident at Sunnybrook and fellowship training in neuroscience, critical care at Johns Hopkins Medical Institute, where he remained a faculty member till 1992. A focus of his research has been measuring the physiology response of therapeutic intervention in critical ill neurology patients using PET. Dr. Dringer has chaired numerous international workshops and consensus conferences, served as second president of the Neurocritical Care Society, and in 2018, he assumed the role of editor-in-chief for the General Neurocritical Care. Welcome, Dr. Dringer. He will talk about osmotherapy. All questions will take them at the end of the session. Please start.
Thank you for that kind invitation, and thanks, Jimmy, for the extra 2 minutes. But my thanks, most importantly, goes to the organizers for this fantastic conference. I'm honored to be here. So osmotic therapy has long been an interest of mine over many years, and after a while, I began to look at our practice and look at the literature, and I began to feel like many of the ways that we were using it or the assumptions we were making about how to use it may or may not be valid. So I want to walk through a series of points that are made about osmotic therapy and review whether we think those are actually fact or fiction. Oh, I have to use this? Okay. So let me just start with physiology, because that to me is really the key to understanding much of what we do. So the observation that osmotic therapy changes brain volume was first recognized in 1919, and This was in the lab where they gave a large dose of osmotic therapy and could visually actually see the shrinkage of the brain. So it was not something you needed a fancy tool to measure. You could actually see the effect. And the way it works is based on the fact that cell membranes are freely permeable to water, and water will move back and forth to maintain osmotic equilibrium. So if you add osmotic particles to the extracellular fluid, water is going to move out of the cells into the extracellular fluid, and that reestablishes osmotic equilibrium. I tried to make a cartoon to make this clearer, and didn't come out so good, but you see the cell, and then you have a blood vessel, and the osmotic particles, and you see that water is moving back and forth in equal amounts and things are stable. You add a bunch of osmotic particles to the extracellular fluid, you have increased movement of water out of the cell, and the cell shrinks. And the other important aspect of this, because you'd say, well, it's just moving from the intracellular to the interstitial fluid, the brain itself is about 80% intracellular. So most of the bulk of the brain is actually the intracellular compartment. So you can achieve benefit by moving the fluid out of it. So this, in summary, is how they work. You get an osmotic gradient between the two compartments. The water moves out, the brain volume's reduced, and ICP goes down. It's sort of very simple and straightforward. But it gets a little more complicated when you have to look over a longer period of time. So up until now, I've been talking about a very acute, the first few minutes, hour, what happens when you give osmotic agents. When the brain cells shrink, they get unhappy. They don't like to be shrunken. And what they do is they generate more osmoles in the intracellular compartment to pull water back in and reestablish a normal cell volume. And this occurs there's an acute phase, which is more related to electrolytes and organic molecules. Then over a day or two, other osmotic particles appear. We haven't identified all of them, so they call them idiogenic. But the number of osmotic particles rises in the cell, and water moves back in. Now, why am I going through all this? Because imagine you've had your patient and you've been giving them osmotic therapy for a while, and now they're in a hyperosmolar state, and the brain has adapted. So now, while your osmolality is high, actually the volume of the brain cells has returned to where they started. So now what happens? You decide, oh, this osmolality is too high, and I need to give some water to bring it back down. And then all the water says, oh, and it rushes right into the cells. And you get this rebound edema, and this is, in fact, exactly what happened to this patient. That was over a period of 12 hours of reducing the osmolality, and the brain, the infarct region just swelled right up. So you have to be very careful if you're using osmotic therapy and you've induced a hyperosmolar state. You need to back off very, very slowly. Okay. So we're all stuck with this. Should I use mannitol? Should I use hypertonic saline? And there's all kinds of arguments. Oh, this one's better, that one's better. I think I'm going to compare the two, and they are different, but not in terms of their effect on osmolality and ICP, but more about their systemic and hemodynamic and renal effects. In fact, so here what you have is the primary mechanism, and you see they both raise extracellular fluid osmolality and draw water out of the intracellular compartment. Now, when we look at the kinetics, this is where it gets different right away. Mannitol is quickly excreted in the kidney and produces a really dramatic osmotic diuresis. And you can see this at the bedside after you've given a big dose. The Foley bag is starting to blow up with what looks like water, and that's the osmotic diuresis. On the other hand, when you give hypertonic saline, that sodium remains in the extracellular compartment. So you don't have that massive, large diuresis and risk of hypovolemia. Both of them raise cerebral blood flow, and probably in part due to the effect on red blood cells. So the osmotic gradient is created for all cells, and the red cells shrink and they become a little bit more flexible, and so they're able to move more easily through the capillaries. They also have some secondary effects that people like to talk about, but are probably not particularly clinically relevant in terms of being a free radical scavenger or anti-inflammatory. So again, to emphasize the hemodynamic effects, one of the big risks of use of mannitol is hypovolemia. Of course, that's something, if you're managing the patient and paying attention, you can easily avoid by adjusting the fluids that you're administering. And then we have adverse effects. So the primary one with, the primary one with mannitol is hypotension. And mannitol has also been associated with acute renal failure. When you use hypertonic saline, you have some additional metabolic problems. You evolve into this hyperchloremic state, and you can get fluid overloaded because you keep giving the sodium and it's not being excreted, and if you continue to do it, the fluid will be retained. Hyperchloremia, metabolic acidosis, and renal failure. So these are some of the concerns with both these agents. I tried to look for studies that compared mannitol and hypertonic saline in ischemic stroke, because that was the focus here. And I could only find one study that indirectly touched on it. And this was a study we did, I don't remember when, but sorry. So this is one of the issues in terms of the studies that compare the two drugs is using equosmolar doses. Often that's not done. So if you want to look at the impact on ICP, you need to be giving the same degree of stimulus with both agents. And if you don't use equosmolar doses, then I don't think you can say very much about the comparison. This was a study we did looking at cerebral blood flow and cerebral blood volume and the impact of these agents on blood flow. And this was in patients, so here on the top line is the infarct core. So this highlighted bar up on top shows you that in the infarct core, cerebral blood flow was quite low, 5. And after mannitol or after hypertonic saline, there was really no significant change in the core of the infarct. If you looked in the peri-infarct region, again, you see minor changes, but these are within the limits of measurement of the system. So there's no change that's going on in the peri-infarct region. When you look at the contralateral hemisphere, however, you see a significant rise or close to significant rise after mannitol, but not much change after hypertonic saline. Unfortunately, I was hoping to give you data with a more robust outcome ICP or something, but there just are no studies comparing these two agents in ischemic stroke. So I had to shift back to TBI, where clearly most of this work has been done with osmotic therapy. And this is a meta-analysis and looking at functional outcome, which is really where we want to get with everything. And you can see in this meta-analysis that it's dealer's choice. There doesn't favor one agent over the other in terms of functional outcome. So what about this one? This is one that when I first started training was a big concern. It was, oh, don't give mannitol, it accumulates in the brain, you're going to get rebound brain edema, and that's a terrible thing. So all of that notion and that concept was based on this single animal study, which was a cold injury model for TBI. So that was the model that they used. They basically exposed the brain and put a cold probe directly on it for a specified period of time. And then they started giving mannitol very frequently and very repeatedly, and what they found was after 5 doses, let's try that again. After 5 doses, you can see all the way over on the side that there was a slight increase in edema in the injured region. So this basically was used to put to rest the use of mannitol. This was another study which was using an ischemic stroke model, again, more relevant to the topic today. And this is an animal model where they got repeated doses of mannitol, spaced out so that they would allow the mannitol to clear the body before the next dose. So I'll come back to that point about clearing the mannitol between the next dose. And you can see the hatch bars are the infarct, the open bars are the contralateral hemisphere, and you can see that there's a reduction in brain water with these repeated doses. These are up to even very high doses, 2.5 grams per kilogram. There was no rebound increase in ICP. There was a continued dose-dependent reduction in brain water. So I think this one sort of goes against that prior study. And to me, although this is a case report, this is a very telling piece of information. This is a patient who had renal failure, came into the emergency department with an acute subdural hematoma, and was given a bolus of mannitol. Okay, so they're in renal failure. That mannitol's not going anywhere. And then they did MR spectroscopy to actually look at the mannitol in the brain. And you know what? Yeah, I have to stop doing this. All the color there you see is mannitol that has leaked into the brain, because you have a damaged blood-brain barrier, as that first study pointed out, and mannitol could leak in. However, they then dialyzed the patient, and it pretty much all went away. So it's not that the mannitol gets into the brain and gets trapped in there. This is simply an osmotic movement across the membrane. So when you have more mannitol in the blood, some of it's going to go in. And then when the mannitol clears from the blood, it's going to go out the way it came in. It doesn't stay there. So while mannitol can leak in, it doesn't accumulate. And then if you dose it properly, you're not going to get any rebound. This is another one concept. This was the idea, and this has some physiologic validity, but the clinical implications are less clear. It does appear that mannitol preferentially shrinks normal brain, and I'll show you a little bit more about that. And the concern was, and this was proposed by Jeff Frank a while ago, 30 years ago. So here's a patient with a big stroke. You have edema. So you have increased pressure, you have a pressure gradient across the brain, and then you give mannitol and you reduce the pressure of the normal brain without changing the infarct, and now you've increased that pressure gradient and you're going to cause more midline shift. So we were trying to figure out whether that in fact happened, and did an MRI study where we took a series of patients with very large strokes who had deteriorated, And there's an example of one of them, and you can see how far their midline is shifted. And we put them in the MRI scanner, got a baseline image of the brain and the volume, and then infused 1.5 grams per kilo, so a fairly high dose of mannitol, and then measured the midline shift afterwards to see if it changed. And these are individual patients, and you can see that it did not change. So did that mean the mannitol didn't do anything? Or did it not create enough of a pressure gradient? So we moved on to a method that actually allowed us to measure the volume of the brain. And it's a very complicated technique, I don't want to get into it. But what you see here again is each individual patient. And you see that the brain is, the whole brain is actually shrinking. And in fact, most of the shrinkage is limited to the normal hemisphere. So the black bar is the infusion of mannitol, and you can see that the brain volume starts to come down very quickly and continues to go down at least over an hour was the last time point that we measured. So, and the other important point to make is the change in volume was between 8 and 12 cc's. We're talking about a very, very small increase in volume, yet that in brains with poor compliance is sufficient to reduce ICP. And it may be that just because of the small volume change that you don't get that midline shift change. Okay, here's another one. Everyone's heard about the 320 milliosmol, you shouldn't go above that. I look back, there's nothing in the literature. If you go back, it started with an abstract that was actually never published and then worked its way into textbooks and became dogma. And so it's really important to go back to where things start. So I wanted to understand, is this actually the cause of renal failure? So how could mannitol cause renal failure? Well, you can get hypovolemia, and hopefully all of you never have that happen with your patients because we're paying attention to their urine output and, okay. Including his 2 minutes? Or? Including his 2 minutes. You could have a direct toxic effect of mannitol. I don't know if you noticed on my first slide, that bottle of mannitol I had crystals growing in it. So if mannitol concentrations in the kidney get too high, crystals form, and that can cause renal damage. Or is it the hyperosmolality? So to move quickly, we looked at a series of patients getting mannitol boluses. We watched the urine output very carefully and made sure they are adequately replaced, so hypovolemia was not an issue. And we found that there was an 11% increase in, or 11% incidence of renal insufficiency. But it had no relationship to the osmolality or the osmotic gap, which I'll show you in a second. And it was primarily predicted by who had sick kidneys to begin with. Chronic hypertension, diabetes, those patients whose kidneys were not up to par in the first place were more at risk for renal failure, really from any cause. The osmotic gap is a really good tool to use because it allows you to compare. You compare the measured osmolality using freezing point depression, the way the lab does it, versus the one you calculate, 2 times the sodium and the BUN and the glucose and everything. And if there's a gap between the two, you can monitor that gap. The gap represents unmeasured osmoles, and in this case, it would be mannitol. It could be alcohols, another unmeasured osmol. So if you have a wide osmotic gap, that means you're not clearing your mannitol. So our practice was to always measure the osmotic gap before giving the next dose. And that way you can be sure the mannitol has been cleared, you're not worried about it staying in the brain, and you're going to avoid problems with your kidneys. The last one is the one that to me is the most concerning, this trend towards infusing hypertonic saline to drive up the sodium. And I first want to point out, and somehow I don't know why this is never considered as part of the equation, hypernatremia is bad for the brain. patients come in with hypernatremia as the primary cause of neurologic problems. And here we are inducing it in patients who already have other active neurologic issues. So I'm not convinced that that's a smart thing to do. And you can see here that the higher the sodium, the higher the mortality in this group of TBI patients. This is a randomized controlled trial looking at infusions of hypertonic saline versus standard of care. And over here you can see in the upper bar what happens to the sodium when you give the hypertonic saline infusion. And over there you can see that it doesn't do much to the intracranial pressure. And why is that? It's because osmotic therapy works as this acute movement of water out. If you're doing an infusion, you get into this steady state, you get the brain adaptation to the osmotic load, and you're going to end up with no effect on ICP, but a hypernatremic patient. And this is a meta-analysis looking at randomized trials in TBI. And this is the top one is good outcome. And again, you see that it crosses the line of identity. There's no benefit of one over the other, yet there's an increased incidence of adverse hypernatremia in the hypertonic saline people. So in summary, hypertonic saline appears to be as effective as mannitol in acutely lowering ICP. If your blood-brain barrier is disrupted, mannitol can leak in, but it's going to leave the same way it came. Doesn't cause increases in midline shift. The renal issues are more about the condition of the kidneys than the osmolality, and at least from my perspective, continuous infusions are not recommended. Thank you for your attention.
It's always a pleasure to hear Dr. Duringer talk about facts and fictions of hyperosmolar therapy. I would like to remind everyone, please stay towards the end of the session. There's going to be the discussion at that time. So for now, I'd like to introduce Dr. Omar Ayoub. Dr. Ayoub is Associate Professor and Consultant of Neurology, Stroke, and Neurocritical Care at King Abdulaziz University. He obtained his training from University of British Columbia, and then a fellowship from Montreal, McGill at Montreal, Canada. He's an executive board member of the Saudi Neurology Stroke Society and was the head of the Neurocritical Care Saudi chapter from 2018 to 2022. Dr. Ayoub is going to be talking to us about management of space-occupying infarct. Welcome to the stage.
Assalamu alaikum wa rahmatullah. Good morning, everyone. Thanks for the attendance. I think it pleasure me to see everybody attending. Dr. Engel, he's my professor. I just give him credit for everything I know in my 14 years of experience now. Thank you very much. Thank you for the invitation in this lovely Kuwait city. This is my second visit to Kuwait, despite the fact I'm 2 hours away from here. Today I'm going to talk about the space-occupying infarcts. And most of my talk will be concentrating on the MCA strokes, which is the majority of our work, and also which has the most of the randomized control trials that we have seen over the years for the compressive hemicoronectomy. So I'm going to go over 2 cases, then go over predictors of MCA strokes that will be malignant MCA strokes, go over some medical management, and then the surgical management, including the evidence behind it. The first case was a 63-year-old hypertensive diabetic presented with 2-hour history of left-sided weakness in dysarthria. Had a gaze preference, field deficit, and NIH of 12. The CT scan at the beginning was very reasonable with aspect score of 8, and the CTA showed occlusion of the M1. This is the CT scan of the first, at the time of the presentation. How do I play the CT? Ouch. It doesn't play on this one. Huh? I want to play a video or clip. No, I don't have the control from here. So as you can see, the first CT was really perfect. It doesn't look bad. The aspect score, as I said, was about 8. Actually, it's even better than 8. And you can see the early signs of the IMSA strokes there. The patient had TPA. There was no thrombectomy done. The next few days was stable clinically. And then on day 5, his level of consciousness dropped slightly. He had the GCS of 10. And as is the usual, we always have to exclude other metabolic causes and everything that may cloud his level of consciousness, and we repeated his CT scan. Can you play it, please? And as you can see, and as expected, it was a major vessel occlusion, and the patient progressed. So this was the repeat CT scan. Patient was not intubated. He was seen by the ICU staff. He was getting brain protective measures, whatever that is. And the day after, the patient had a decreased level of consciousness down to 3, and seen again by the neurosurgery. And again, the neurosurgeon did not want to do anything, said this is not a candidate for decompressive hemicraniectomy. And as you can see, the stroke expanded, and with hemorrhagic transformation, midline shift, and so on. So stayed in the ICU, intubated, had pneumonia, PE on top. There was debate of do we anticoagulate or not for the PE? What do we do with the hemorrhagic transformation? The patient stayed for about 16 days in the ICU and eventually died. The second case is a 65-year-old with the same risk factors who presented with M1 occlusion and left-sided weakness, had no TPA because she came in beyond the TPA hours. She was treated conservatively. The GCS at the beginning was 13, and then the 4th day had a drop to 6. She was seen at that time, evaluated, had a repeat CT scan, excluded everything else that can lead to the progress, and given measures to decrease the ICP, and the neurosurgeon was contacted. And then discussion with the family was made, and she was taken to hemicraniectomy, extubated the 2nd day, and then went home about in 20 days after the admission. So from these 2 cases, they are non-randomized, case control, no placebo, single consultant, double center study. Look at the outcome, look at the cost on the system, look at the effect on the healthcare in general, the effect on the patient. Let me add one more to the story. The first one was done, I think it was 2011. That was when I just came back from my training. And the evidence was not that very, very strong to support decompressive hemicraniectomy. And the second case was in 2016, I believe. And we had more data and more evidence to support it. And if you know the practice, I think in Saudi Arabia or in the region, at the very beginning, at that time, 2011, if you talk to the neurosurgeon about decompressive hemicraniectomy, they always say, no, we'll not do it, especially if the patient has dominant hemispheric infarct, if they have aphasia. And I think that debate was going on and on for years. And over the years, I think things have changed, and we are pushing more to decompressive hemicraniectomy in the right time, in the right setting. So think about the morbidity, potential mortality, if you don't do the right thing for the patients. So deterioration in stroke happened because of a stroke progression, because of the edema, sometimes because of the bleed, either it's hemorrhagic transformation or because of what we do in terms of thrombolytic, thrombectomy. There is still a risk of expansion because of it, and also recurrent ischemia. When the edema happened, it depends on the location, the age of the patient, the volume that you can calculate it based on the diffusion or the perfusion images, and also the degree of existing atrophy. And that's why the younger the patient is, the more likely they have the expansion, because they don't have enough room for the stroke to expand within a closed compartment. It peaks within 3 to 4 days, but can be earlier, especially when you open up a vessel into a necrotic tissue. These are some of the predictors that you can think about when you look at those patients. So age will play a major factor in predicting who are the patients who are going to have expansion of their stroke and also the edema. If there is arterial hypertension, and that was beautifully lined out by Dr. Jamil, the NIH stroke scale would indicate the severity of the stroke, and also it can predict large vessel occlusion. If there is decreased level of consciousness at the beginning, the presence of nausea, vomiting, pupillary asymmetry, of course, and the presence of fever. And some of the radiological indicators or predictors, if the MCA was affected in more than 50%, and classically more than 2/3 of the MCA, if the volume is more than 82, and let me remind you that most of the studies that were done on the decompressive hemicoronectomy included volume of more than 140. If there is heart failure by the echo or by the evaluation, if there is a midline shift more than 5 millimeters, and if you have one more than MCA, so if you have the ACA or the ICA included or the PCA on top, then the patient will more likely to be going into major infarct. This is a CT scan of a patient who has more than 50% of their MCA infarcted, and that's how you calculate the volume. So you take the ABCD divided by 2. There is the adjusted way and the unadjusted way. So at the end, if you calculate the volume, it can give you more push of which patient should go for decompressive hemicoronectomy in the right time by calculating the volume. And that is the classic midline shift, more than 5 millimeters. And these are the basal cisterns that you have to look at and evaluate in your decision. So when it comes to management, at the beginning, you have to try to prevent anything that will increase the edema and increase the expansion of the stroke. So avoid excessive free water, avoid hypoosmolar treatment, don't put D5 deliberately, avoid excess glucose, and control your hypoxemia, hypercarbia, and also avoid hyperthermia. So maintain proper normothermia. Avoid any antihypertensive that cause cerebral vasodilatation. Hydralazine, I don't like it as you are. And head of the bed has to be 20 to 30 degrees. And then when edema developed or when the ICP is in question, so you treat it exactly as you are treating the TBI or the spontaneous ICH. Hyperventilation, hypertonic saline, or the osmotic diuretics. And sometimes you can do the intraventricular drainage in specific cases, and eventually you have to go for the definitive treatment or the prevention of death, as I call it, decompressive surgery. There isn't enough evidence to support hyperventilation or steroid or diuretic or mannitol or glycerol in ICP alone. So these are temporizing measures that if you want to use it. And of course, I don't use steroid, but this is one of the things that is being discussed in the literature. The mannitol dose is between 0.25 to 0.5 grams per kg. I usually go with 1 gram per kg and then divide it across the day. Hypertonic saline in transcensory herniation can reduce the ICP rapidly and elegantly. Dr. Deringer has told you everything you need to know about the osmotic diuresis and also the hypertonic saline. Your target hypocapnia is a PCO2 of 30 to 35. And also, if you keep in mind that the death rate or the mortality can be up to 80% in patients with massive MCA. So you have to be quick and you have to start the temporizing measures in the meantime until you reach to the decision of the surgical treatment. These are the first 3 trials, which was the Destiny, the Decimal, and the Hamlet. And simply, they had a smaller number of patients within each paper. So the first one was 32 patients, and then 38, and 64. The most important message, or let's say the inclusion of patients in these 3 trials, they were a bit similar and different in some ways or the other. But if you look at it, they included patients who had what we call massive MCA or malignant MCA or large MCA stroke, and they have decreased level of consciousness, and they have more than 50 or 2/3 of the MCA affected. And in some of these trials, they included patients who had volume estimation of more than 140 cc. So if that was the case, they have to include patients, and then they have to randomize them and do the surgery within, in some of these papers, they were done within the next, let's say, less than 48 hours. One of them had more than 48 hours after the incident. The bottom line of all of these trials at the beginning, it was very good in improving mortality. So there was significant drop of mortality if you compare patients who were treated medically versus surgically. The absolute risk reduction in general in all of the trials over the years is about 44%. And then based on these 3 trials, there had been review articles, meta-analyses that indicated that if you combine together all of these patients, the effect is not only on mortality, the effect also in morbidity, and also in outcome. So the functional outcome of patients, if you took MRS of 3 as good functional outcome after decompressive hemicraniectomy, so these trials or these procedures will improve the patient outcome eventually at 1 year. And also after these trials, people were not enthusiastic to operate on patients who are older than 60 year of age, and this is one of the trials that answered that question, or partially. They took 112 patients, more than 60, within 48 hours of onset, and again, the mortality benefit was significant in that trial. These are some of the major randomized control trials that were done over the years: the HEAD first, the HEMI, the MID, Demeter, and then two papers by Zhao and Sleasons. So, as I told you earlier, that at the beginning there was a very big discussion about decompressive hemicraniectomy. Does it work or does it work? Should we do it? When do we do it? Does it work in patients who have aphasia? Does it work in patients who had multiple vessels involved? This is one of the nice meta-analyses and systematic review where they took randomized control trials that were done in decompressive hemicraniectomy, and they had very balanced characteristic in terms of the patient's age in either group, either surgical versus medical. And at the end, they have concluded that, again, decompressive hemicraniectomy doesn't matter if the age is less than 60 or more than 60. Doesn't matter if the NIH is bad at the beginning. Doesn't matter if the patient had aphasia or not. Doesn't matter if it is a dominant or non-dominant hemisphere. There is benefit when it comes to mortality, and also there is benefit in terms of favorable outcome if you take the MRS of 3 and more. Less than 3. This is a visual representation that patients will significantly improve if you compare between the mortality, which is MRS of 6, between the medical versus the surgical group. And as you can see as well, patients who had been in favorable outcome in the MRS of 3 also had increased significantly. And that's also a visual representation of the forest plot. And as you can see at the end, the intervention or the decompression had always been, not always, in most of the parameters that were studied had been better. One of the nice papers that I went through was the European Stroke Organization Guideline on the Management of Space-Occupying Infarct. What they have done it through the GRADE protocol, where they have the PICO, which is the population intervention, then comparator and outcome. And then they have generated questions. What are the things that we should do in each patient? And these are some of the questions that I pulled out. So the first question that was done, in patients with space-occupying hemispheric infarct, age 18 up to 60, the surgical decompression initiated within 48 hours of stroke onset as compared to no surgical decompression reduced the risk of death or poor outcome. And that first question had the most of the trials that were done over the years, and the answer to that is yes, decompression is highly recommended. The evidence was moderate, and also the recommendation was strong. And the expert added to the recommendation that yes, we have to do decompressive hemicraniectomy regardless of aphasia, regardless of the presence of either the presence of ACA or PCA in addition to the MCA, regardless of if the patient had hemorrhagic transformation or not, and also the diameter of surgery, it has to be at least 12 centimeters. So the larger, the better. And one of the papers had indicated exactly how do you do the hemicraniectomy to be effective in reducing the ICP. The second question, what about if we delayed the surgical intervention? So in patients with a space-occupying hemispheric infarct, between 18 and 60, the surgical decompression initiated more than 48 hours of stroke onset as compared to no surgical intervention. Does it reduce the risk of death of poor outcome? There isn't enough data to support it. There are some of the trials that address the question of more than 60, so they had to be conservative about their recommendation. But I think, for me, I think we have to do it. Either it's less than 60 or more than 60. And their expert panel had recommended again that it has to be done, especially when the patient has more of a signs of herniation. The third question, In patients who had space-occupying hemispheric infarct, age more than 60, and the answer was surgery has to be considered. In patients with cerebellar infarct, which I did not go over in details, does surgical decompression as compared to non-surgical decompression reduce the risk of death or poor outcome? And as we stand today, there is no randomized control trial to address that question, but simply when you have large cerebellar infarct, it will compress eventually on the brainstem. It will cause hydrocephalus, and it's important to consider all surgery. But again, we don't know exactly by the trials what is the exact time that we should intervene, and also should we do it alone or we should do it with CSF drainage. And the experts on that question said, consider surgery with or without CSF drainage, and the timing of surgery is uncertain. The last question is, in patients with space-occupying cerebellar infarct, does CSF drainage reduce mortality or improve functional outcome? And again, we don't have enough data to support it, either to do it alone or together with surgery, or we should not do either one. And an option by the expert opinion that the option has to be considered alone or with surgery whenever it is clinically indicated. So at the end, please do decompressive hemicraniectomy in patients who had massive MCA or possible cerebellar infarct. Thank you very much.
Thank you very much, Dr. Omar, for the informative presentation. Our next speaker will be Dr. Susan Yeager. Is a neurocritical care nurse practitioner at the Ohio State University Wexner Medical Center, Columbus, Ohio. And she serves as the president of the Neurocritical Care Society. She will speak about dysphagia. Welcome, Dr. Susan.
Thank you. While they're putting that up, I would like to thank the organizers for this opportunity to speak with you all today. I would also like to thank all of you for still being here. So thank you for that. It is much appreciated. That's okay, no problem. Aren't these guys great? Let's give them a hand while we're waiting. All right, again, thank you for that. I hail to you from The Ohio State University Wexner Medical Center. It is in the United States, specifically in Columbus, Ohio. I have no financial disclosures, but I need to disclose that I'm the president of the Neurocritical Care Society, and I'm an ambassador for the World Federation of Critical Care Nurses. I also need to disclose that I'm not a speech pathologist, and so I'm giving you the clinician perspective of dysphagia and the neurologic patient. Pathophysiology is where I'm going to start, and then I'm going to go over the approach to evaluating the patient, and then the best evidence on treatment strategies. So before we actually get into the rest of how to treat patients, we need to start with what's the definition. So the definition of neurogenic dysphagia is the impairment in food or liquid transfer from the oral cavity through the pharynx and esophagus to the gastric entrance. In looking at a meta-analysis, you can see that acute CVA, the phase of dysphagia, is anywhere from 42 to 75%, depending on how you evaluate that. Complications of dysphagia can be pneumonia, malnutrition, and an inability to really participate in rehabilitation. Mortality in stroke with dysphagia has an increase in in-hospital mortality, and also is a risk factor, a second most common risk factor for death besides stroke severity. So there are various phases of dysphagia. It starts with the mixture of the food with saliva, goes where the anterior portion, the tongue goes to the anterior portion of the hard palate, then the posterior portion occurs, and then the food transfers to the vallicula, and then the jaw drops, the tongue drops, and it goes down into the esophagus. And with each phase of swallowing, each piece can be a portion of dysphagia. So there was a classification that's a systematic review and identified there were 7 phenotypes that were present in stroke patients. And you can see I highlighted the ones that are specific to stroke: premature bullous spillage, delayed swallowing reflex, and also the residue in the piriform sinus, as well as pharyngeal, laryngeal movement disorder. So as you're likely all aware, there's various ways that swallow is initiated. There are cerebral cortex that initiate it, as well as the brainstem and cranial nerves. It's important to recognize that there is some thought that there's interconnectivity between the hemispheres that then can translate to a later compensatory recruitment on the contralateral somatosensory side that then can cause neuroplasticity, which then leads to a recovery from dysphagia. So who's at risk? There's 10 studies that were done in this meta-analysis, and they said elder age, but they didn't specify what elder was, hypertensive, diabetes, as well as brainstem stroke. Additionally, there was a study that was done in Switzerland that looked at an age greater than 70 and an age greater than 14. And then really the frontal OPER curriculum was also where if the lesion was there, you were more likely to have dysphagia. Additionally, in another review, they were looking at a retrospective study that had about 350,000 patients in it, and facial palsy, aphasia, as well as the stroke severity depending on the location of the stroke. So a supratentorial stroke with an NIH of 10 or more, or an infratentorial stroke if it's less than 6. So why are we screening? Why do it in the first place? So we talked about the mortality piece, and in 26 observational and 6 randomized control trials, there was variability in the screening of patients, but what they found is that there was a protective health benefit of screening for pneumonia, mortality, dependency, and length of stay. In another retrospective registry of 350,000 patients, decreased in-hospital mortality was also found with screening. So how do we screen patients? What do we do? So there's a bedside swallow component as well as instrumental dysphagia evaluation. We're going to talk about both of those things. So in looking at a Cochrane review, you can see there were 25 studies that were reviewed that included about 4,000 patients, and there were 37 screening tests that were utilized or evaluated in order to see their impact on stroke. And what they found is the best tools in stroke patients were the bedside aspiration risk, the Gugging swallow screen, and the Toronto bedside swallowing screen. However, these were single studies and there were small sample sizes. In a systematic review, there were 20 tools that were looked at in the acute care setting, and below are the swallowing techniques that were found to be the most beneficial. These are the Yale Swallow Protocol, the Gugging Swallow Screening, Toronto Bedside Swallowing, the Sapienza Global Bedside Evaluation, as well as the 2-step thickened water test. And all of these were developed primarily in stroke patients, but the Yale Swallow Protocol was actually utilized in stroke, MS, TBI, and neurosurgical patients. In addition to those bedside swallowing studies, there are additional instrument studies that can be utilized in order to evaluate swallowing. The first is fiber optic endoscopic evaluation of swallowing, and the second one is video fluoroscopy swallowing study. And we're going to see in this next slide the comparison of the two. The FEES study actually can be completed at the bedside. It can be completed routinely. There are no time constraints that are related to this. The unfortunate part is that there's no visualization of the oral phase. And again, in each phase of swallowing, There can be dysphagia, and then there's actual swallowing you don't see, but what you see is residual in the vocal cords. With the video fluoroscopy swallowing study, it allows direct assessment of the oral, pharyngeal, and esophageal phases. However, there is exposure to radiation in this study, and then there's difficulty with patient positioning. So in our patients that have TBI, or if there's a patient that has hemiplegia, this study is a little bit harder to perform, and then it uses barium rather than real food in order to evaluate the patient. So how do we go ahead and practically go about evaluating these patients? So you're going to start with screening. If there's an expert available, you're going to go down and start with a water swallowing screen. And then if they're low risk, you're going to go ahead and start oral intake. If they're higher risk, you're going to do a more detailed evaluation, which includes those fees or modified barium swallow. If you do not have a dysphagia expert or a speech therapist available, you're going to do a multi-consistency swallowing evaluation, and then you're going to begin oral intake with multi-consistency ongoing evaluations with these patients. So again, why do we care? So dysphagia, it's important to know that dysphagia does not equal aspiration. So aspiration occurs when you have the swallowing piece, there's reflux, and then the secretions actually invade the airway through the pharynx and the glottis. And this is mainly caused by laryngeal insufficiency. The incidence of dysphagia in stroke patients is about 10%, and of those 10%, 33% of those patients develop dysphagia and then go on to have pneumonia. So what do we need to look at the bedside? We need to be looking at dysphonia, dysarthria, abnormal gag reflex or absence of that, cough after you swallow, voice changes, and hypoxemia with this. Microaspiration can occur, and so again, that hypoxemia piece is important because it may not be demonstrated in other ways. So now we've defined it, we have identified how to evaluate it, and now we're going to go on to management strategies in order to prevent the complications that we talked about. It should be managed by a multidisciplinary approach, again, speech-language pathologist. Diet preservation, so we'd like to feed these patients as soon as possible, and liquid modification into thicker consistencies will assist with that. Additionally, textured food, soft pureed versus your regular diet, and then temperature modification. And then trying to do various techniques will also help. So alternating food and water, as well as minimizing distractions in patients so they can focus more on the swallowing. There can be changes in the head extension, chin tuck, and head rotation, all as ways to try and help with things. And then some unique ways to do this. You can ask the patient to hold their breath after the food is in their mouth and then swallow. Again, that obviously closes the vocal cord passage. And then have them cough after swallowing and then swallow again. And then another technique is hard swallow repeatedly. And then finally, the Muscasco maneuver is where you hold your tongue outside of your teeth after the food bolus is put in. You keep that tongue outside of your teeth and then you swallow repeatedly. There are also strengthening exercises, so this is a way to try and recover from this. The shaker technique is where you raise your head and you keep it off the bed for a minute at a time, and this is shown to decrease aspiration in 9-study meta-analysis. There are some unique techniques that are incoming, and that includes the pharyngeal electrical stimulation that is done through a nasogastric tube that goes into the esophagus and causes stimulation. And then there are some transcranial magnetic stimulation that can occur. Additionally, there are non-pharmacologic interventions that can occur. Those are listed here for you, as well as up and coming is real-time MRI evaluation, pharyngeal sensory and motor evoked potentials, as well as the digitalization and machine learning that will occur as we move forward. Thank you. In conclusion, it is a common neurocritical care diagnosis. On high-risk dysphagia, you are likely to have, or at risk to have, aspiration. Standardized testing should occur, and this should be a multidisciplinary, not only evaluation, but then treatment strategies in order to prevent further problems. Thank you very much for your time and for the opportunity to speak with you today.
Thank you, Dr. Yeager, for that talk. For now, I would like to invite all our esteemed speakers to the podium. I would like to have you seated on this direction here. We have 15 minutes of questions and discussion. So to start, I would like to ask the audience if there's any questions for any of our speakers. So we'll get you your microphone.
Thank you so much. I have two questions. The first one regarding blood pressure control. We all know that cerebral autoregulation differ from patient to patient. So how to individualize blood pressure targets or ranges, or just stick to the guidelines, certain figures or certain numbers?
Your question is how to individualize?
Yeah. Or just stick to the guidelines, certain numbers, 130, 140?
Yeah, no, I agree. I mean, I think in today's world of everything we do, it's customized is the way to go, from getting clothed to managing blood pressure. But 100% you want to individualize. I mean, they gave a range with some provisions. And the studies are imperfect. So the large ICHs that come comatose, we don't know what's actually the range, because all the patients that were studied were actually higher GCS, lower NHSS, and mostly also deep hemorrhages. The second thing is if they come into 40, do you drop them down to 140? Is it healthy or not? There's some recommendation larger than 60 millimeter per mercury at once. It's also devastating, more than that. So the bottom line is, yes, you have to individualize. So if they're markedly high and in the 240s, 230s, then you want to be, don't drop them down to 140. So then you want to just bring them down, say, by 60 millimeter mercury within the first hour and gradually work your way down. If they come in with a blood pressure of, just 140, 130, because they have a, say, malformation, then you want to keep it in that range, let them do whatever they want to do. You don't want to even drop it below where they are. So absolutely, but I think most of why they give that range as well is most of your patients fall in that category of what they presented. So that's why it almost fits most of the patients.
Thank you. The second question regarding osmotherapy. That sometimes we hit the target or above the target of the osmolarity is 330, and this, okay. We use, for example, mannitol for the patient, okay, brain edema, midline shift, and we reach the osmolarity 330, and still the patient has brain edema and midline shift, and we don't know what to do. The next step is to stop, to wean gradually, or to search another solution to decrease this midline.
Tell me if I understood correctly, if you're saying that if you reach the osmolality of, say, 330, what do you do then? Do you continue or, yeah. So it's hard to know. No one has really established what the upper limit is. I would base my decision on the patient's clinical condition. So are they stable, are they improving, or have they not improved? And then also I find the imaging is a helpful guide. If you're treating big stroke with edema and you can see how much mass effect there is, then you can help you make a decision. I think if the patient is deteriorating and you haven't improved the imaging, then I think you can go further. One other option is, remember with mannitol, if you adjust your replacement fluid appropriately, so don't necessarily use isotonic saline, maybe half normal saline, then you can avoid the osmolality going so high, but still get the benefit of osmotic therapy. So you give the bolus of mannitol, and then you wait until it clears, and then so the osmolality comes back to where you started.
Okay, thank you.
Any further questions from the audience? We have a question here.
Can I argue that point? I think you elegantly stated that the actual number of 320 was based probably on fiction rather than fact. So given the fact that this is what we know so far, that it was only an abstract or something that we don't, do you measure serum osmolality, or is it necessarily to measure serum osmolality when you give mannitol? Honestly, I'm not that picky on that osmolality thing at all.
So I measure osmolality when giving mannitol to establish the osmotic gap. So we tend to use relatively high doses. And to me, the most critical thing about avoiding getting into trouble is to make sure the mannitol is gone between each dose. You don't need to measure osmolality at the peak or, that's not helping you. What's helping you is just to make sure you've cleared it all. And that's the only situation where I'd measure osmolality using mannitol.
We have a question from the audience.
Yeah. Can I give two questions? Is that okay? Yes. Thank you, yes. So I work in my question for Dr. Ayub. Thank you for the excellent decompressive craniectomy talk. I think you convinced everyone. I work in a mixed trauma, neurotrauma, post-neurosurgical unit, and we get these daily large hemispheric strokes coming in, and we have difficulties triaging them. Like how do you predict who's going to evolve into malignant cerebral edema and who's going to need a decompression? Do you have any practical, innovative tools or like a tactic for
You want the
triaging?
simple answer? No. Everybody here in the room, if they practice enough, I think you would know. It is extremely, extremely difficult to know which is which and who is who. And there isn't clear answer, as I illustrated in my lecture, that the patient come with this and this and this and that, take them immediately to within 48 hours to the surgery, because you'll face patients who had at the beginning very reasonable CT scan, and then all of a sudden, depends on their collaterals, depend also on their reperfusion, depend on what you have done with them, depend on your unit. Some of them, they may expand, some of them, they will never expand, and also you'll say, okay, would I have done the surgery, or should I have done it, or should I not have done it? I think that was always a difficult question. So for me, as a practical point, so if the patient is fully conscious and let's say all the predictors that were not there, so it was less than 50% of the MCA is infarcted, the volume is not that large, I wouldn't go immediately for an early intervention. But if I saw one of these parameters had been reached, and I'll depend also on the level of consciousness, just right at the beginning, I'll push for the surgery at that time. And I think there's also a lot of, let's say, debate. Some of the surgeons or the neurosurgeons still in the practice of saying, when the patient deteriorates, call us when it's too late. So I think that should be taken out. I think it can be valid in some of the situations, but in cases of MCA, I think it will be extremely too late to intervene when the patient had deteriorated.
Yeah, I'll add just, I don't have an answer as well, but, and that's where the technology or advancements, we all wish to have. So like the high-grade subarachnoid that you don't know if they're spasming or not, are you gonna herniate or not? So we wish to see a continuous, non-invasive, something you put on the head that has a TCD, EEG, optic nerve sheet, all these non-invasive that, I mean, they're all spot checks, right? So something that is technology-based, that is continuous, that is equivalent to your nursing check, that is Q1 hour, that's also not enough. I think what we're trying to do is doing, for example, pupillometry. So you have a right MCA stroke, and you know certainty they're gonna herniate. Maybe closer checks of the pupil and NPI, all these numbers go in the wrong direction. That could be helpful in a patient that you cannot follow the exam. That's just one thing to have. Excellent. Maybe in the future we'll have continuous technology.
Thank you very much. I have another question for Dr. Diringer. You gave us a very nice comparison between hypertonic and mannitol. Like, would there be any advantage to using both in an alternate kind of fashion to hopefully you gain the benefit of the molecular nature of each one?
Yeah, a great question, and in fact, that is a strategy that I have often used. So, in different, for instance, if you know you check your osmotic gap and you see the mannitol is not completely cleared, yet the patient's ICP is rising, that's the perfect time to give hypertonic saline, and then you can alternate the two. You'll have the same benefit in terms of getting water out of the brain, but you won't end up in such a hyperosmolar state. So yeah, I think that's a very wise idea.
Any further questions from the audience? So actually, I have a question for Dr. Jaeger. From a nursing perspective point of view, I'm just going to take you away from that dysphagia and then bring you back to the whole concept of actually following the patient on a regular basis, because we just heard hourly neuro exams from a nursing point of view might be not enough, especially in the critical phase. So how would you approach a patient that doesn't have invasive monitoring, has non-invasive, and what would be advised as to the nurses?
So in my institution, we used the Yale study. As I shared with you, there was broad application for that, so we only have to teach the nurses that one type of study. So we use that. We look at the indicators before we start as to whether or not there's tongue deviation or a facial droop as something as an indicator that may have trouble, or if they're not managing their secretions to begin with, that would not be a time where you're going to even test the swallow. If they're not managing their secretions, they're not going to be able to manage any of the fluid boluses that are there. We end up where if they pass that, then we would proceed forward. The only time that we would make changes is if there was a change in the clinical exam. So in the situation where you have a large hemispheric stroke and the patient's neurologic status decreases, or we start noticing the other signs and symptoms that I talked about, like the dysphonia, the potential hypoxemia. We had a gentleman just right before I came that had the microaspiration, that really the only thing that we saw on him was the hypoxemia. So we only do it the one time if they're doing fine. If they're not doing well from the beginning, or we're not quite sure, that's when we move into the fees, which is generally what we do as a first start. And then if they're well enough, they go for the modified barium swallow, but really it's more fees at the bedside, and that fees would be done every day or every couple days.
Thank you. Any more questions from the audience? Yes, we have one more question there. Okay, I have a question for Dr. Dringer. You said that we can combine both hypertonic saline and mannitol. Is there any increased risk of acute renal failure? Because each one of them have the risk of causing renal failure. So do you think by combining both of them, we will increase the risk of renal failure?
So, yeah, I left out in answering the last question, one of the other circumstances where we would alternate is if you have been giving mannitol and you see the creatinine starting to rise a little bit, then you would switch to hypertonic saline to allow the kidney to recover. Remember, the injury from mannitol is probably the direct effect of the mannitol. And in a kidney that's already been damaged, you get some crystals and it sort of tips things over. Whereas with hypernatremia, it's more the prolonged osmotic state and the hyperchloremic metabolic acidosis. So the mechanisms are different, so if you alternate, you can hopefully stay out of trouble.
Thank you. Okay, yes?
My question for Dr. Susan. In your hospital in Ohio, do you have SLPs in your entity? Who will implement this stroke protocol with dysphagia patients? Because usually in Kuwait, we do it, the speech pathologist. So I just would like to know the difference in your hospital, if you're following the protocols or the SLPs. Thank you.
So our speech therapists are available routinely Monday through Friday, and then we have them available on Saturday and Sunday, but usually on a very limited basis. So we have the bedside nurse initiated again if there aren't those specific factors that are present. So any of the items I just talked about. In that case, we make the patient NPO. We're going to put down a jejunal tube and then start feeding. So we do that with a tube feed. So that's how we manage it. Our speech and language pathologists are really beyond what are just the basic.
Okay. Thank you very much for our distinctive speakers, and thank you very much for the audience to staying with us. This is the end of our session. Thank you.